Hey everybody. Today I'm going to be sharing my PICO question that I chose for my final essay and presentation. And that is, do tracheostomies improve growth and reduce ventilator dependence in prolonged mechanically ventilated pediatric patients? My name is Nolan Gukazel, and this is for the Department of Respiratory Care. Respiratory Care 355 is the class. This PICO question originally came about because through working in a pediatric ICU and a CVICU and kind of wanting to know more of the in-depth research that the team pulls upon to make the decision to trach or to remain intubated, or just some of their reasons and the indications that come about. So the focus of this presentation is going to be to explore indications, conditions, and just reasons that the pediatric population gets trachs, benefits of trachs in the prolonged mechanically ventilated patients, and the relationships to growth factors, specifically to weight and length of the patient or height. And then the last one's going to be a comparison between trachs and intubation, oral intubation in this case, and short-term versus long-term decision to trach when that is made, and then some of the complications of either. The target audience for this presentation is going to be healthcare professionals, respiratory therapists, registered nurses, advanced practice providers, and physicians. The objectives at the end of this presentation, I would like the audience to be able to answer and understand the reasons for tracheostomy placements in the pediatric population, and then benefits of tracheostomies in comparison to long-term mechanically ventilated patients via oral intubation. So first, we're going to go over indications and contraindications. According to Nora H. Chung and Lena M. Napolinto, in 2014, said about 10% of mechanically ventilated patients undergo tracheostomy. So that's a pretty big number. It shows how long-term a lot of intubations are. And then some of the main reasons for tracheostomy are prolonged intubation, inability to successfully wean or in a rapid pace wean from mechanical intubation, easier control over pulmonary hygiene through a definitive airway, any upper airway obstruction that you're able to bypass, difficulty with intubation for airway malformation, or like the previously mentioned obstruction, difficult airways in general, and then other things that may, like the head or neck surgery trauma that's going to make difficult intubations, or abnormal anatomy, and then airway protection such as neurologic disease, traumatic brain injury, things that can also affect ventilation long term. So this slide is going over benefits and growth. The Z-score represents standard deviations from 0. So this is showing growth at a 6-month, 12, 24, and 36-month period for all the different cohorts, or all the different kind of conditions why kids may be trached. So in this, you can see the 12, 24, and 36-month period. That's usually post-discharge at that point, remaining fairly consistent. So that's giving good evidence to tracheostomies and the growth and thriving of the patient long-term is what this really indicates after discharge. Obviously, the 6 months, they're growing the most while they're in the hospital, but post-discharge, they remain fairly consistent. So in this study by Akingri, G et al. 2020, they noted that all patients with trachs had G tubes as well, and this allowed for a consistent and reliable source of nutrition. And they noted that in the study, the mixed disciplinary care team is crucial to be able to have these patients thrive both in and out of hospital. They really took note of the dietitian and nutrition staff able to provide these patients with a caloric intake to grow, respiratory therapists, nursing for the care of the patient, And then also in-home care, education to the family or care providers, long-term care facilities, whatever that may be. But they said those are crucial to minimize the caloric expenditure and help the patient thrive outside of the hospital. So now we're going to go to tracheostomy versus intubation. So intubation has a higher likelihood of ventilator-associated pneumonia, airway trauma from movement of the tube, or using the laryngoscope during intubation. Higher that you're obviously able to extubate more easily, tube dislodgement, resecuring and adjusting the securing device always poses a threat to accidental extubation. For tracheostomies, they can primarily be divided into 3 stages for complications. There's early or immediate, early, and late stages, and each one has kind of unique concerns and complications. So the immediate stage, a lot of times we see hemorrhage or bleeding, often from the stoma site, structure damage to the trachea, the failed procedure, that's always a risk, and things like loss of airway if there's airway collapse, and the hypoxemia and hypercarbia would be due to obviously an inadequate airway. Early complications can still be the hemorrhage, the tube displacement, pneumos if they're not ventilating correctly, or if they're in a false pouch. Other pneumomediastinums, the subcutaneous emphysema, those are all from air not being directly ventilated to the lungs. Infection could be a large concern at this point, so proper trach care is very important by ENT for the first week or the respiratory care staff, depending on what the policy of the facility is. And then accidental decannulation. They need to be secured, whether they always have trach ties or possible sutures in place to hold it in for the first week or so. Late complications can be stenosis, granulation, pneumonias and aspirations from any airway, fistulas, and accidental decannulation. But I would say the most common would be the stenosis and granulation tissue, just from any irritation of the trachea at that point. It could be from too much inflating of the cuff. It could be from movement, routine suctioning for a prolonged amount of time, causing irritation. So this study showed, J.H. Lee et al. Showed that patients who underwent tracheostomies at or before 16 days or 14 days on the ventilator, showed a reduction in ICU stay, mortality, and ventilator dependence compared with long-term intubated patients. So specifically, this study found that the length of hospital stay after tracheostomy were significantly shorter in tracheostomy group that with the shorter tracheostomy group rather than the late tracheostomy group. So that was 14 days and under was considered early or shorter. Later was 14 days and after. Also, the incidence of ventilator-associated pneumonia before tracheostomy was 2.6 per 1,000 days in early tracheostomy group, and the later group showed 3.8 per 1,000 ventilator days in the later group. So after tracheostomy, the occurrence of VAP was per 1,000 was 1.2 versus 1.9 from the early and late. So overall, length of ICU stay is generally longer. Ventilator-associated pneumonia is also higher in groups of patients being trached after 14 days of oral intubation. And obviously, this study doesn't take into account other factors in that decision, possibly extending the oral intubation to avoid a trach if the patient's going to recover. So there's a lot of factors in it that this study didn't take into account, but it's looking at those main outcomes and complications. Little difference was observed in outcomes such as length of mechanical ventilation or mortality rate post 1 year of the tracheostomy. Here's a little video link that would be great to watch. Unfortunately, we don't have a ton of time, but it just goes over some of the common complications with tracheostomies. It does mention loss of voice, psychological distress, speech delays, smell and taste issues, and aspiration risks. Typically things were not thought of in a hospital for short-term complications. We think a lot of times of dislodgement of the airway or hemorrhage. So this does a great job of speaking of physiological distress, just not being able to speak, emotional stress, and other things, just not being able to do daily activities of living as normally as they were once able to. It's something that they have to cope and rehab with. Here are my references, and this is the end of my presentation. Thank you guys. I hope you enjoy.